Welcome to Diagnostic Accuracy for the Scholarly Clinician, Highlights and Bottom Line. This is ATTR 712, Evidence-Based Medicine. It's important to understand that this following presentation is simply the highlights of the readings that are assigned for this week. So please make sure that you are reading all of the assigned readings for a better understanding and a more depth understanding. This PowerPoint will simply go over some of the highlights and key points that I'd like to discuss this week. When we look at what we're going to cover, we'll talk about specificity and sensitivity, positive and negative likelihood ratios, validity, and reliability. So many of you may be familiar with sensitivity and specificity, and what we'll do is we'll define each of these individually, look at how they are mathematically calculated, and then talk about what they mean. Sensitivity is how often a test detects a disease or a condition when it is actually present. In other words, how good a test is at correctly identifying the condition of interest. So if you have high sensitivity, this means that you're able to detect the test or detect a pathology, or the test is able to detect the pathology when it is actually present compared to the gold standard. And when we look at the values, if you have a sensitivity of above 0.8 or 80%, that's considered high. If you have a sensitivity between 0.6 and 0.8, that is considered moderate. Anything below 0.6 is considered good to poor. And we really don't want to concern ourselves with the tests that have below 0.6 sensitivity. On the other hand, you have specificity, and specificity is how often a test is negative in the absence of the disease or condition. In other words, how good a test is at correctly identifying the absence of disease. So when you, let's say for example, use the Lachman's test, when you get a negative Lachman's test, specificity will tell us how good you are at actually not having a torn ACL. Similar to sensitivity, our values are above 0.8 is high, 0.6 to 0.8 is moderate. When we look at the tables and calculations for this, you can see how sensitivity and specificity are derived. Sensitivity can be defined as the number of true positive tests divided by the sum of true positives plus false negatives. False negatives would be tests that you as a clinician identify a negative. So you would say, let's just use the Lachman's test for the remainder of this presentation. So a true positive Lachman's test would be if you're on the field and you do a Lachman's test and you as the clinician say they tore their ACL. They have a positive Lachman's test, and then they go in for surgery, and during surgery when they cut them open they see that the ACL is torn. That's a true positive. A false negative would be when you do an on-field assessment doing the Lachman's test, you come back with a negative test. So you as the clinician say they definitely didn't tear their ACL, but as they develop, they end up going for surgery, and then they're in surgery, and then the clinic or the surgeon sees that they did tear their ACL. So you tested that they didn't tear their ACL. In reality, they did tear their ACL. Specificity, on the other hand, can be calculated by taking the number of true negative tests divided by the sum of true negatives and false positives. So we'll use the Lachman's test example here. So specificity, a true negative, is if you do the Lachman's test and it is negative. You don't identify a torn ACL. And then as part of this experiment, they take the patients in and they scope them and they see that they did not tear their ACL. So therefore your clinical test was identical to the gold standard, both non-torn ACLs. When we look at a false positive is a condition, or is a situation where you as the clinician get a positive test. So you're on the sideline, you do a Lachman's test, that comes back positive. You refer the patient for surgery, they go in for surgery, and in the event when they cut them open, they see that the ACL is not torn, so it's intact. That would be a false positive because the clinical test suggested that they had a ACL tear, but however, when they went in and they looked at the ACL, they found that the ACL was intact. Specificity and sensitivity, and all of these positive and negative likelihood ratios that we're going to talk about here in a second, they all go back to the gold standard. And the only true gold standard for diagnostic accuracy testing is surgery or arthroscopy. And in looking back at the functional anatomy, even MRIs and CT scans and X-rays, which we think sometimes are gold standards, had to have been validated with arthroscopy or functional anatomy. And most of our, and depending on the conditions, sometimes our MRIs have a sensitivity and specificity of 0.9, so they're not always perfect. So the bottom line with sensitivity and specificity, sensitivity really measures the true positive. So a higher sensitivity means that we have very few false negatives. And if you want to remember this, you can remember snout, sensitivity SN, and out, sensitivity out, snout. If sensitivity is high, a negative test will rule the disorder out. So if we have a very high sensitivity and we get a negative test, we can be fairly certain that they do not have that disorder. So, for example, if the Lachman's test, and this is just an example, we're not talking specifically about the diagnostic accuracy of the Lachman's test, but in a hypothetical situation, if the Lachman's test had a very high sensitivity and we tested them and we found that they did not have a torn ACL, therefore we had a negative test, we could be fairly certain that we could rule this disorder out. On the other hand, specificity measures the true negative tests, or the ability of the test to detect negatives. A high specificity means we have very few false positives. And to remember this, we can use the acronym SPIN. So if specificity is high, a positive test will rule the disorder in. So, for example, with this Lachman's test, again, if we have high specificity and we do a test and we find that it is positive, so we have laxity in the joint, and we as the clinician determine that that individual has torn their ACL based on the Lachman's test, we can be fairly certain that the participant or the patient has that disorder. So for a test, ideally, we want a test that has high specificity and high sensitivity. That way, if we want to rule it out, our sensitivity will be high, and if we want to rule a certain pathology in, we want our specificity to be high. In reality, it doesn't quite work like that. There are very few tests. I mean, there are some tests that have high or good specificity and sensitivity, but to be honest, most of our physical exams fall in that moderate range, and most of our diagnostic imaging falls more in the higher end with above 0.8 specificity and sensitivity. But it's important to understand that even our MRIs and our diagnostic imaging aren't 100% accurate. The next thing I want to talk about, which kind of goes right in with sensitivity and specificity, is what's called likelihood ratios. And likelihood ratios is a different approach to specificity and sensitivity that assesses a clinical test performance. It's unaffected by the incidence of the condition being assessed in the given population. And it incorporates estimates of sensitivity and specificity, just like I mentioned, but into a clinical useful value. So the problem is sometimes specificity and sensitivity, it's hard to interpret what that actually means. When we look at a positive likelihood ratio, this confirms a positive result of a clinical or diagnostic test, and vice versa. A negative likelihood ratio excludes a negative result of clinical and diagnostic tests. In a little more depth, Positive likelihood ratio is the likelihood that a positive test will be observed when a person has the condition versus the likelihood that a positive result will be seen in a non-affected population. So think of this is a higher positive likelihood ratio is used when we have positive tests, and we want a high likelihood ratio because it's an odds ratio to the number of people who will come up positive, who are actually affected by the condition, versus the number of positive tests when we have someone who's not affected. And so let's use an MRI example for this. If we take someone with a torn ACL and we stick them into an MR scanner, and they have a torn ACL, we know they have a torn ACL based on surgery, etc., or based on functional anatomy, etc. We should be able to scan them, and the scanner should be able to say, yes, you have a torn ACL. Then that ratio should be higher than if we took someone like myself who has intact ACLs, no history of any ACL trauma, and they put me into the MR scanner. It shouldn't say that I have a torn ACL, or it shouldn't read that I have a torn ACL. However, sometimes there'll be individuals where the MR scanner or the radiologist who's reading that will say someone has a torn ACL, when in reality they don't. When we look at some of these values, anything that's above 10 is considered a large positive likelihood ratio, 5 to 10 is moderate, 2 to 5 is small, and 1 to 2 is very small. And taking into account specificity and sensitivity, with sensitivity for a positive test, you want a large likelihood ratio. That a sensitive test with a large likelihood ratio would probably be a good test to use. When we move to the negative likelihood ratio, again, it's an odds ratio that when a negative result from a diagnostic test with a small likelihood ratio suggests that the chance of having the condition is very low. So we want a very small negative likelihood ratio. And a small negative likelihood ratio, the smaller the negative likelihood ratio, the better. So for example, if we do a strep test, and my strep test comes back negative, I want to make sure that I will have very few false negatives. So when the test tells me I don't have it, I want to make sure that I really don't have it, that it wasn't that the test was accurate enough to rule out any possibility of me actually having strep test. You can think about it let's move it up to a more serious condition. Let's say cancer. You want to make sure that if you're going to give, let's say, someone a blood test for cancer or a scan for cancer, and you're administering this test, or the physician's administering a test, and the test comes back negative, and you're really, really happy because now you don't have cancer. Now think about the effects, the implications if in reality that test wasn't very good, that blood test wasn't very accurate, and it said you were negative, but you actually had cancer. This would delay treatments, this could cause the progression of the disease, etc. There's a whole number of negative consequences if we use a test with a high, or I guess a very small negative likelihood ratio. So when we go back again looking at these values, the smaller is the better. So for example, if we have less than 0.01, that's considered a large negative likelihood ratio. 0.1 to 0.2 is considered moderate, 0.2 to 0.5 is considered small, and 0.5 to 1 is considered very small. So to review, for positive likelihood ratios, we really want large numbers above 10, and for negative likelihood ratios, we want very small numbers below 0.01. A couple other statistics that I want you all to be familiar with moving forward and reading the literature, specifically the diagnostic accuracy literature, is reliability and validity. Reliability is the extent to which the results of a test can be replicated when the same phenomenon is measured under the same conditions multiple times. Okay, so how often can we do this exact same thing and get the same results? There are two main types of reliability: intra-tester and inter-tester. Intra-tester, is we want to check the reliability within the same person. For example, if I was going to if we were going to do a study where we wanted to see the intra-tester reliability of a clinician's ability to take goniometric measurements, we would have the same clinician measure the same person's knee flexion with the same goniometer multiple times. And ideally we want, in order for that measure to have high intra-rater or intra-tester reliability, we should get the exact same numbers every single time we take goniometric measurements. Inter-tester, on the other hand, is between clinicians or between different people. So if we want to look at the same experiment where we look at measure the reliability of goniometry using a standard goniometer, we want to test inter-rater or inter-tester reliability. We would have, let's say, 5 clinicians go measure the same person once, and then we would compare the measures between each of the clinicians. When we look at test-retest reliability, this is another type of reliability that we see in the literature sometimes. This is presented as ICCs, or interclass correlations. We have two types: Pearson correlation coefficient and intraclass correlation coefficients. Pearson correlation coefficients, you're going to see most of these on cognitive variables or maybe some affective variables. More often than not, in the examples that I was giving before, based on with the goniometric measurements, we're going to be seeing intraclass correlation coefficients, ICCs, between testers and between occasions. This is important because these are the type of statistics that you're going to see in a paper. So if you see when you're reading a paper and it says ICC equals 0.8, 0.9, 0.99, that ICC is interclass correlation, and that's really the reliability measure. If you're also looking at some other correlational coefficients, the Pearson's R, you're going to see R equals, and that's going to be a measure of reliability, or how closely those measures are related. The next step is, and I guess the final piece of this puzzle, is validity, the extent to which a test measures what it's intended to measure. So let's talk about this. Validity is, if I say I'm going to test your knowledge, for a test to be valid, that means it actually has to test your knowledge. You'd be surprised at the number of tests that are not valid. Think about this. How many times have you had a professor who may teach you stuff where you're asked to maybe just recall or maybe memorize some things, like let's go anatomy. You need to memorize the brachial plexus. And so you've memorized the brachial plexus. If you see a picture of the brachial plexus, you can redraw it, you can relabel it. And you know where the sensory nerves and the motor nerves and the mixed nerves are located, and you know, red trucks drive cats bonkers. Like, you've memorized it and you completely understand it. But then when it comes to test day, your professor asks you to write an essay about the importance of the brachial plexus in the upper extremity. Okay? He asked you in class to memorize and to understand the structural components. But then when he asked you about the importance of it in context of the upper extremity, he is asking you about the physiology or the function of it. Therefore, that's probably not a valid test question. so the validity can extend beyond just scientific research, but it really extends into everything that we do as clinicians. And there are several types. There's face validity, content validity, criterion validity, and construct validity. The primary categories are internal and external, and that's what we'll focus our time on. Internal validity really deals with if the treatment produces the proposed change. So does weightlifting improve strength? And external validity really deals with the generalizability um, of our findings or of our test to a larger population. There are several threats to internal validity. This includes history, maturation, testing, selection bias, regression, experimental mortality, instrumentation, and selection interaction. But we have several, and you'll talk about this in statistics class, so I don't want to go over it too much, but we do have strategies in terms of research design where we can counteract these threats, including randomization, different statistical controls, using matched pairs, blinding, placebos, and maybe categorizing subjects or participants into different categories. When we look at external validity, the major threats are multiple treatment interference. So if you're going to measure the effect of foam rolling on range of motion, but every time you move someone into hip flexion, that puts them that stretches out their muscles. Are you changing the baseline measure every time you take a measure? So therefore, is the experimental protocol or the measurement protocol yourself interfering with the results? And if you do that over multiple times or multiple days, are you actually improving flexibility through testing their flexibility, or is the treatment that you've applied improving their flexibility? We also have interactive effects of testing, the selection treatment interaction, and reactive effects of the experimental arrangements. When we look at the values, so when we're actually going to read this in the journal articles, it's often used. You often see validity discussed in terms of the gold standard. And there's the gold standard for everything. Well, hopefully there's a gold standard for most things we do in athletic training. For example, when we talk about diagnostic accuracy, the gold standard is arthroscopy, or functional anatomy, cutting someone open and looking at the anatomy. The gold standard to determine whether an ACL is torn is to open the person's knee up and see if the ACL is torn. The validity or the gold standard for measuring joint range of motion is digital inclinometry. So actually measuring the incline of our different limb segments. The gold standard for body mass is underwater weighing. So all of our BMI calculations, all of the electrical impedance scales that you stand on with the little silver spots on the bottom, they are all considered valid, or some of them are considered valid compared to underwater weighing. And you'll see these in a couple different forms. You'll either see Pearson correlations or Spearman's rows, and it really depends on the type of data that the research is using. If it's using interval data or ratio data, you're going to see it presented as a Pearson's correlation. If it's using ordinal data or nominal data, you're going to see it presented as Spearman's row. And just as a refresher from your previous statistics experiences, nominal data is data or are data that are where codes are assigned to objects, and they're selected as labels. So, for example, if we wanted to run a statistical analysis on hair color, I can't type in black, red, brown, blonde, green, dyed, gray into my statistical analysis software and run a quantitative analysis. I have to, maybe everyone who has black hair is labeled 1, everyone who has green hair is labeled 2, everyone who has red hair is labeled 3. And that kind of gets to this next point. There are no actual values assigned to the code. The next one is ordinal, so that's rank data. where whether you finish first, second, third, fourth, fifth, 100th. That's that type of data. Interval data is data where there is equal measures between units, and there's not really a true zero. So this is a lot of the data we see when we collect some of our physiologic measures is considered interval data. It's along a continuum, and there's no true zero. For example, our reflexes or our spinal level of excitability in our spinal cord isn't zero, and everyone's different. So we don't have a true zero. Now we can create a zero if we standardize that, but all of the data are presented in a way where we can't understand a true zero, and that's kind of where ratios come into play. And it's an estimation of the ratio between the magnitude of a condition of a continuous quantity and the unit of magnitude of the same kind. So this is how scientists and a lot of time scientists and clinicians overcome the barrier of having interval data. Is they present that data in the form of ratios, and that allows us to have a true zero. And we can see these in confidence intervals, odds ratios, likelihood ratios, risk ratios, any number of effect sizes. If you've ever heard the term effect size, those are actually ratios that are based around a true zero in order to give us some more clinically relevant information. Again, this is just a primer, and we will be reinforcing these ideas and giving you more experience with these ideas, throughout the program, and especially when you get into some of your statistics class and your integrative care classes, where we're taking EBP and holistic care and merging them together as one. In conclusion, again, this brief primer, I know is about 25 minutes. But essentially is just a very high-level review of the different concepts that you'll be reading about this week. And, and when we think about diagnostic tests, and you think about diagnostic accuracy, I think the most important thing for a clinician to pull away is that the only true gold standard when it comes to accuracy of tests and diagnostic accuracy of tests, particularly orthopedic problems, is to look at the functional anatomy. So it doesn't matter how good a Lachman's test or an anterior drawer test or a pivot shift test or active compression, modified labral shear test. It doesn't matter Faber's test. It doesn't matter what test it is. There is always a chance for error, and we see that even in MRIs. Most people would consider that MRIs are pretty close to the gold standard, and I would agree, especially with increased technology. But the only way to 100% be sure is to go in and look at the functional anatomy, and that's why I've kind of given you this picture of an arthroscopic image of maybe how they would do one of these tests, where they would put someone in the scanner and say yes, no, did you tear your ACL based on the scan, and then they would stick a scope in your knee to look and see if they tore the ACL. And in this case, this individual has an intact PCL. However, you can see the ruptured ACL between the femur and the tibia. And with that, I think we've finished up this lecture. If you have any other questions, please let me know.